So I'll be talking about 3D visualization system. Now, microscope has evolved over the time, and we keep wondering whether we progressed or regressed. So this is where in 2018 the 3D visualization system came into picture, which is called the Ingenuity. We took this because, or we adopted this to take care of three people. One, the doctors, the next the patients, the next the trainees. Now coming to the doctors, as you all know, it's been an occupational hazard of ophthalmologists to have neck pain and back pain, and it's become a big issue. Especially if you're training the trainees, you end up sitting in a very awkward position where you're, because of the bed height and the microscope height is not matching, and you end up with a lot of pain by the time you finish training. But with the coming of the 3D microscope, you can see me, you can really relax your back on the chair behind, and then look at the screen and operate. And the training is even better. You can stand anywhere in the OT, you don't have to sit also, look at the screen and train the trainees. The next thing is, how do we take care of our patients? As you all know, 3D system, we use low illumination, because of which the patients are so much more comfortable. Eventually they cooperate more, and eventually surgical outcome also is more. And this is 5% illumination, which is amazing, operating at that low illumination. The next thing is taking care of our trainees. It's been a really boon for trainees, and it has really shortened the learning curve. And as you all know, the side viewing of a microscope, you're limited to one or two trainees looking through it. But with 3D system, no matter how many people are there, you can just wear cheap 3D glasses, look at the screen, and you're good to go. And it doesn't matter whether you're just a fellow who's just joined or a senior fellow. From day one, you can look at the depth perception. That way, you pick up things really, really quickly. So I just want to show a series of cases using the 3D microscope. This is a soft cataract, and yes, you can chop every soft cataract. It is extremely easy. This is a dialer which I designed myself. So with this, chopping is extremely easy. The technique is you need to do it slowly, and also do not rush it, because then it'll start cheese wiring. Now, obviously, chopping in a softer cataract is NS1, NS2 and above is much easier. The key is, whenever you get a good hold in the phaco tip, please do not move it or push it. That way you prevent iatrogenic zonular breaks. Even doing rexus in an intermittent case is extremely easy. In fact, this is one of my first cases, and usually I create a smaller rexus in the beginning, and then I extend it so that I prevent these kind of runaways. So here you can see even the viscoelastin being washed from the endothelium. That is the beauty and the clarity of the Ingenuity, and this is actually a zoomed out video of the same. Here you can see me polishing the posterior capsule, and for just a microsecond I hold the posterior capsule and release it. And let's look closely at the same. See, you can see me holding, the capsule is held within the aspiration cannula, and you can see the spidering of the capsule. But I release it. This can happen only if there is no lag in the system. If what is happening in reality is exactly what you see in the screen, then only the reflex is good and you prevent the complication. So here's a black cataract. Even doing a surgery on a black cataract is extremely easy. The key point is, whenever you're doing quadrant removal, always place the phaco tip in the center. Do not shake it when you're pressing step 3, and I always remove my second instrument so that it creates a better fluidics within the eye. So we did a study where we compared the Ingenuity system, or the 3D system, with the standard operating microscope. This was a prospective randomized study where we had 224 patients and 5 surgeons. We looked at the ease of visualization of the different steps of phaco surgery and also post-operative outcomes. This was how the scoring looked like, which was given to the surgeon. And when we look at the results, the doctors had much more discomfort when they were operating on a standard operating microscope, and they operated on a very low brightness and illumination on a 3D system or an Ingenuity system, which is amazing. And overall, the patients also were very comfortable. When we look at the post-operative first day AC cells and flare, there's no significant difference between the two groups. And when we look at the ease of visualization of the different steps of cataract surgery, there was no significant There's nothing significant between the two groups. And when we look at the subgroup of metro cataracts also, the results were quite similar. So I'd like to conclude by saying the surgeon was able to operate at a significantly lesser illumination and brightness with the 3D system. It provides better neck comfort, and also significantly the patients were more comfortable and more cooperative using the Ingenuity, and hands down a superior tool in training students. Thank you for your time.
I just had one small doubt whether this is adaptable with any microscope or
no, it depends on the company, sir.
Because the kind of clarity which we are seeing is probably possible only with very high-end microscopes.
Yeah, it all depends on which company you go with, sir. So depending on that, sometimes the one company goes with their
Ingenuity is compatible with all microscopes.
Yeah, but
the
not the
other
Zeiss. The Zeiss.
Yeah, it is compatible with Zeiss.
But not the low end, they don't. The lowest end.
I don't know. I mean, Lumina onwards, they do work.
That's the key. The only issue right now is the cost. Costing is the issue, sir.
But obviously, when you go up, the resolution would be better, the red glow would be better, and as he rightly pointed out, you can really go down on your illumination. Yes. But just an interesting, just an observation. The first two surgeries that you showed, Naren, were post-flax.
Right.
So, any reason why you did not choose to do a nucleotomy with the flax machine? And
actually, in fact, I personally don't do it. Don't do the nucleotomy because, see, I personally...
You don't do the nucleotomy with flax ever?
No, I don't do it. That is because, see, for me, I feel if a patient is paying something, I shouldn't, at least they're paying for a very premium surgery, and I don't want to add one more set of complications for him. So in the sense, at least in my hands, doing a regular chop or this, there's absolutely no difference. But when we do a lensectomy, especially in these hard cataracts, the bubbles itself, I've had cases with that itself has led to a PCR. So it's extremely, I don't want to add that 1% or 2% risk of, a PCR occurring just because there was excess bubbles and then it led to a PCR. You feel bad that it's not happened in your hands. It's more because of the machine. But that's one of the reasons why I don't do it.
But is there a need only with the femto, because there's no pixelization in this?
Yeah.
Right?
To tell you the truth, sir,
no, as you go on, increasing the magnification, still the clarity is maintained. That is the beauty of the Ingenuity.
Yeah. The zoom.
So will there be any need at all, as he was also asking for the femto and other things, we could otherwise do away with the regular things, because you're seeing so better and clear.
In the microscope or the Ingenuity, sir?
No, with the Ingenuity system.
Correct, sir. So what is it required, sir, you said?
No.
He's saying there's no need of flax if your visibility is so clear,
and
so crisp.
Perfect.
So the thing is, sir, more than the clarity, I would say no matter what the machine is, finally the actual benefit of flax is the rexus, period. Not the incisions, not this. The main benefit of the precision and consistency of the rexus is actually it's because of the rexus which the flax create. Usually the surgeons cannot create because nobody knows what is the center of the bag. No surgeon can predict that. We can approximate, okay, this is the center or something, we can just do it. But what these femto machines do is they actually center it to the bag, which will be the centration where the lens also will happen.
Yes.
So that is the actual beauty and the huge benefit of flax. That's my belief. The rest of it is so minuscule, it really doesn't matter. In a surgeon's, skilled hand, definitely.
With all humbleness, I would agree to disagree with you. To me, the main crux of a flax procedure is the corneal application and not the rexus, because I found it to be extremely beneficial in my practice. But we are digressing from the topic. Let's just come back. Okay. So you mentioned that you, on occasions or quite regularly, as we know all of you do right at your center, you handle a massive or fatty load of surgeries almost every day. So what's the percentage of 3D in the anterior segment, in cataract surgery, in phacoemulsification in particular? What's the percentage of 3D surgery in your practice? Do you do all of them under 3D?
Yeah.
So when you have 20 surgeries, just citing an example, at the end of those 20 surgeries, do you feel any strain on the eyes? Of your eyes, not the patient's eyes, your eyes?
Not really, not really. Actually, that's part of the study where we looked at the comfort from, how easy is to visualize or does he have any issues. They were extremely comfortable. All
The
5
reason why
surgeons.
I'm asking this to you is because the 3D technology is of two types. One is active and the other is passive
Right,
3D
right.
technology. The active 3D technology actually switches off and switches on between the two
Right,
eyes, so
right,
it
that's true.
keeps on flickering. And the glasses that you use for the active 3D
passive.
are powered
all
glasses. They have
passive,
to be battery powered or battery charged. The glasses they give you with Ingenuity or Artevo are passive 3D
Passive
glasses,
ones,
but yet they pixelate the picture, they layer them. You have around 300 layers for the left eye and 300 layers for the right eye. So at any point in time, you're actually seeing monofocal, and then the superimposition happens in the brain. So I had an issue because I have taken a demo for quite some time, and I did have issues after a long list for the day. I did have issues with the strain factor. So had I been one of your respondents in your questionnaire, I would have definitely not said that I'm very comfortable using. Agree to the other points though, but and say in 1 out of 100 cases wherein you needed to switch back to the. Have you ever had that? I'm in a situation wherein you come back to the microscope view from the
No, absolutely not.
engineer.
I think in terms of doing the surgery, absolutely no difference. If any complication also there, all the surgeons continued with the same. And plus, answering to your first question, I think it's extremely important to see when we comparing two technology. Obviously, you cannot have that much of experience on a as much as a microscope. But at least what we did is we didn't say, okay, start operating. We didn't ask the 5 surgeons or 4 surgeons to, okay, from today you operate in the 3D. So what were before the study, they were made to operate on the 3D system, so they get used to it because it's important. Whatever it is, even a phaco machine, you give it today to an experienced surgeon, and just 1 day or half a day experience, you say, okay, now you decide. Sometimes it's getting used to the system. Once he keeps using on a daily basis, they come to one comfort level. Then we compare the two technologies. That's how the study was done.
So which, according to you, is the biggest advantage of this technology? The surgeon's comfort or teaching the budding surgeons?
Both.
If you have to choose one of them.
If I have to choose, in terms of percentage-wise, training is even more.
So have you ever tried to ask one of your trainees which gives him better depth perception and understanding of the procedure? Watching it on screen or watching it through the side scope?
Absolutely. No doubt only about it. Yeah.
So
hands down, there's like they never remove the 3D screen. That's what happens. The whole surgery, they're just always wearing the 3D screen, looking at the screen continuously, where they have options because in the OT we have other TVs also. We have the video is coming in the Callisto or some other one more monitor which was there from long before. There also the video comes. But eventually everyone looks at this screen and then sees it. Because
that's obvious because all the other monitors are 2D, even the Callisto monitor.
That's when you get the depth perception.
No, I was asking you, have you tried to compare from their perspective? Have you tried to compare it with the visualization of the video or the procedure or the steps through the side scope? Because that's also something that gives you 3-dimensional viewing. No technology can ever evolve which has a better 3D perception than human eyes.
So what happens is, see now if I'm operating, again seeing through that, they will break their neck and bone. There's no doubt only about it. He has to be my same height, same this, everything should be there because otherwise, adjusting to that kind of a level, and also there'll be a bend forward also. When you see a trainee or a person who's teaching or whoever seeing through the side viewing, he'll never match the primary surgeon. So it's extremely difficult on a long. Actually, if you today, if we go home and ask one of the fellows or trainees who you're training, if they ask them like the whole day after they keep seeing through the side viewing, how you're feeling, how's your neck and back, just ask one question. more than enough. All the answers come in.
I oversee, I'm a standalone practitioner, so I don't have, but I would seriously like Dr. Paul to,
100%.
because he trains a lot of
On the
people.
we can actually call
going
now
through
the
side
call
scopes,
and ask.
how does it compare, sir? I mean, you must have had loads of it. So, do you really think that your trainees have
the trainees are
necessity?
definitely better, enjoys, and they to see better than your observer scope.
One small doubt which I had. Does the refractive error of the surgeons play any part in their comfort levels?
Yes, sir.
Have you done anything to...
No, definitely, sir. We have to correct the refractive power. So he has to, if
No,
the surgeon...
even with the correction, like somebody who's having, say, supposing -3 cylinder and somebody who's emetropic, their level of comfort, are they comparable or they're different?
I personally haven't looked at it, sir. But I mean, thinking about it, I mean, it shouldn't make a difference because once we wear the glasses, eventually we are all like zero power eyes, so it shouldn't make a difference, sir. But one crucial thing is majority of our trainees are under stress, so they eventually they sometimes over accommodate and other things. So on a regular basis, we keep checking their eyes to make sure that they're not, because half the time they don't see and they keep operating. So it's extremely important to, sometimes if it's your focus and the trainee's focus is not matching, send them to orthotics immediately.
Some surgeons use monovision. So would be seriously advisable to them to use their glasses and use their binocularity. Otherwise, you would not have the same depth perception ever.
One other added advantage is that the assisting sisters, even they have the feel of...
yeah.
that is also an added advantage.
So
yeah.
Thank you.
Thank you so much.
Thank you.